Hi, here we go. One more time. Here laughing again. Today we have a really special friend and guest, and that's why we were laughing because I think we've been friends for like 12 years, and he still doesn't understand my English. So
More than that.
we
More than
more
that.
than that, right? And,
Yes, more than
and we telling stories because I still imagine how my English was 12, 15 years ago. Still having issues, so now I'm trying to get the best for him to see he can follow me a little bit. So we have here a friend from Canada, Curtis Westernen, and he is been a great friend. We take courses together, and we've been in this journey for many, many years in different phases of neuromuscular and physiological occlusion. And it's a pleasure to have him here. We're going to try to take advantage about many, many years into the neuromuscular arena to tell us how it's been his evolution in thinking and how he's applying all the concepts involving posturology that is a big part of the what he does, and that's what he's going to lecture in the marathon. But let me pass it to Hamid because we've been the three are friends for many years, so we have personal
Yes,
stories together. And so
that's
I would,
right. And I have my own story of Curtis. So back in 2004, when we just started going to the school to learn, my first purchase was the K7, and the second purchase was Curtis's information or explanation CD for patients, because I knew right away, and he's been always so great in marketing and really a genius in that arena on his own. So yeah, we go back quite a bit. I still have those CDs, Curtis.
CDs, of course, are not used anymore. Nobody can use them. But yeah. Back then in 2004, that was cutting
State
edge.
of the art.
my God, we go way back. This is a journey, really beautiful.
We were just talking about both Javier and I were on the stage in Moscow, Russia, and we were being with Konstantin Ronkin, and we had the use of a translator to take our language and put it into Russian. Now I speak English, so that's one language. Javier speaks is Spanglish, and so we had this poor lady who was trying to translate what he was saying into Russian. I couldn't even understand it. I got a better Russian translation than I did an English translation.
You see, you go by challenges in life, but that's the beauty. Oh my God,
Yes, we've,
Japan
we've
was
given up
even
on
worse.
that. Now we're learning Spanglish. We're Javieronese, we call it.
Yeah, I think that's good. If I could get influenced, I will influence it. I kill everybody's English, so don't hang too close. Okay, so Curtis has been doing this for how many years, Curtis?
I've been a dentist for 41, starting 42.
My God, you look
And
younger than that. You have
yeah,
makeup?
I just look older. I've been doing TMD for about 20 years.
Wow. So we want to see or want to hear from you. How was that first experience? Why, after practicing too many years, just in a regular way, you start finding new horizons, and we want to see how this process when you go into this, because I relate this with the book of Cynic that is called The Infinite Game. And the infinite game, you know the rules and where who is gonna win. Is gonna be always a winner. You know everything that is gonna happen is predictable. But in the infinite game, it's no rules. The game never finish. It's just that you need to be committed to play and enjoy. And I think that's what we do, and that's what we think we did never stop. So how has been this journey with you in physiology of occlusion? Give us a little thinking about how you get engaged in this fascinating world of physiology.
Okay, Javier and Hamid, imagine that you're having a discussion, quote unquote, with your wife, and you say that you did something and you did it perfectly, and she says, no, you didn't, or you didn't do it perfectly, and then you realize that she's right.
That's like every day in my life. Just kidding.
That
Well, I know.
was my experience with figuring out about occlusion. And I mean, there was some village missing an idiot because I was doing dentistry. And suddenly I realized everything that I was doing was messed up. And I had a lot of TMD issues. I got rebuilt early on in my career. I got rebuilt by a prosthodontist. And for some reason, started having migraines, neck aches. My neck was cracking all the time. I was grinding down my teeth that he hadn't put porcelain on. I was chipping the porcelain. And then I went to LVI and I listened to a chiropractor talk about occlusion. And I'm going, that makes sense. And I came back and I started doing that, but it made sense for a while, and then it wouldn't make sense for everybody. And if it, I by chance met a good friend of mine, Jeff Schulten, who's a chiropractor for the neck. He just works on his upper cervical vertebrae. And we started working together, and it started providing better answers, more stable answers. And from there, I mean, I got a passion about it. I wanted to learn, okay, what's next? And then what we were just talking about this. Well, airway is pretty important. What type of airway are we doing? What's the physiology that's happening here? Why does that sign or symptom show up when you're trying to make yourself figure out what a patient's problems are? And you know, it's a pretty deep well we dive into, and we really get out there in the weeds, looking at all these nuances, and it just keeps us going and going and going.
So you start just with regular neuromuscular dentistry, and then what was your next training in something related with physiology? Rocabaro. What inspired you to go deeper in posture?
I mean, there's once I started realizing that posture is a huge part, that was a whole growth session right there. I don't treat posture. I have someone else treat posture. I started realizing how I could integrate that in my practice, and when I should integrate it in my practice, and how often I should integrate it in the practice. Then, because of my interest in posture and physiology, I took some Rockabata courses, and you know, he's great and he's wonderful. I just reread his 2 handout books the other day. Last weekend, I spent last weekend just reading Rockabata and just trying to remember everything that he told me. It was really great. You know, I've been to Jay Gerber's understanding, LVI's understanding, and just trying T-Scan, Robert Kirstein, and I've done lots of work with Robert. And of course, who's our grand mentor? Norm Thomas, Dr. Norm Thomas, and how, you know, all the information that he's able to give us. And he would always make us, I don't know about you, YouTube, but every time I went to one of his ICMO courses or pre-courses on physiology, I felt like an idiot.
Oh,
Because
totally.
he was talking about
club,
stuff
yeah. I don't
that,
know how.
that I had to go into Google and look all this stuff up, and then, okay, well, how's that connected to that and everything else? And so it became, I might say, a passion to try and learn that. And now I've got a son that's in dental school.
Wow, how awesome is that?
And he's in 2nd year. And so now it's more of a passion about how I can help him start off on the right foot.
That's beautiful. What have you noticed in these 20 years doing physiological occlusion that has been changing? Are we adding new things? Are we making any new protocols? Because all the physiological occlusion and all the concepts in general has been having a little push for the new technologies. That's how everything started, I think, with Jan Kelson, that he started developing instruments to measure, right? And then after, still technology coming up to the equation that can help you to measure another things. Like that's what I mentioned, that you were combining the utilization with T-scan in your treatments, utilizing with TENS and all that process. How has been this transition to instruments for you, and what can be the most thing that you like about the integration, about force, timing, and the combination with TENS?
What I've been able to do is I've been able to see my patients having three problems. And those three problems are: one, the bite is imbalanced. Second problem is the bite's misplaced, forward and back, up and down. And the third is that the bite's being influenced by posture, by other things that we have to deal with our patients. And so what I've been doing is I've been trying to integrate various forms of biometric measurements to, one, diagnose problems, that's one, and then two, to try and figure out the appropriate treatment modality for these patients, so that as we move forward, as we get into this, we start to see that there is really complicated problem, but we actually, if we nail it down to these three problems and figure out how to solve these three problems, we help a great majority of the patients for a long time.
You want, yeah, want to go, or I keep asking questions? Because
No, no,
honestly, this is tough questions because we pretty much think in many situations the same, and we want to do this for the audience.
no, it's a little bit interesting how he has simplified his views. It's easier. We've been talking with Javier that perhaps we have a little bit too complicated a method right now, and sometimes when we go to explain things to people, it can scare people when you know it's a complicated setup. And this view sounds a little bit like some of the other speakers we had, where they have simplified their diagnostic work into 1, 2, 3 steps or so. Now, in this way, which one of these cases are easier for you because of the new instrumentations that you use, or has that is that because of the tech scan that you're able to make this delineation in the cases?
Okay, so I'm going to let you in on a little secret. I don't really tell everybody this, but Hamid, I will tell you.
Thank you.
For the last 41 years, every single patient that's come into my office has a head connected to a neck, and then a torso, and then some assortment of limbs. I never get a box, and I open it up and I go, "Oh, Mrs. Smith, how you doing?" So I never get that, right? I always get a patient. So what I'm trying to do is simplify the fact that I can't do everything myself. So I need help, not because I'm a village idiot, it's true, but I can't do everything myself because I'm only allowed to do teeth. But the teeth are connected to this patient. And so I need to help this patient in a variety of problems and conditions they present with.
How much percentage into the treatment? And I'm just gonna ask you this because honestly, when you review the lectures, you will see how many different holistic approaches we have with the different guests that we have. And many of them, they've been really successful in treatments, and they've been based everything in the science of mastication, the mastication cycles. And then they come with a really interesting point, because I suffer that when I go and teach courses in cultures that the economy is different, that they cannot afford technology. And most people believe that many of the philosophies are equipment dependent, right? So one of the questions is, do you think that you were in an island in the desert? Can you practice what you do without equipment? What can be the simplest way that you can treat a patient with the knowledge and the experience, of course, as I reinforce that the technology gives us experience because we get to see too many of these traces and behaviors and measuring data that now can give us some level of expertise that how you will simplify what you do in a patient that you're in an island and you don't have nothing else. What can be that approach in that implying all the physiology in a more simplistic, holistic way?
Okay, so well, what would be the simplest way to check someone's bite? Javier, what would you do to check someone's bite? You use some ink paper.
Yeah, exactly.
Okay. And there's many studies that show that even though we are the Jedi Knights of articulating paper, the marks that we see do not tell us the actual force, timing, and duration of the bite. Basically, when we see marks, we're making a wild guess. If you think someone has a cavity, how would you assess that?
Yeah, with an
Take an
X-ray,
X-ray, right?
but I can tell you that if you're in the desert and you don't have that, it's no X-ray. And I seen in my country people doing root canals with no X-rays, and even here in the state when it's these all campaigns and stuff like that, has to happen something like that.
Okay, well, you know what? The only thing you need, and I got this from a movie. The only thing you need is a figure skate and a rock, and you can actually use the figure skate and the rock, and you can bash the figure skate until the tooth comes out. Tom Hanks did it. I mean, he's not even a dentist, and he was doing it. So that's all you need, a figure skate and a rock. How's that? Should we just go with that? Is that what we're going to limit ourselves to?
No. But it's just to know.
Okay.
Because if you ask me that question, I will say, okay, I understand posture, so my skills for diagnostic and full body analysis, let me see where the patient can have the rotation. Even that we're not treating the patient in the postural pattern, we know that bites couple with these relations, and we know that we can influence the posture through the bite. So then I will use my knowledge and see what he has. Let's say that I don't even have a TENS unit. Then I will take what I call a cranial bite, or I gag the patient, or I take a swallow bite or something, and I will do some sort of device to put it between the teeth. So who say what we do cannot be done without instrumentation, I can tell you that we all treat patients that they pregnant and with pacemakers that we cannot use electrical stimulation, and still is heat and massage therapy and techniques to get some muscle relaxation. So it's still ways holistic. So that's the point that we're trying to do. We want to show that maybe since we are in the biometrics life, because we decide that we're more anal people, that we like to really measure everything, to be harder in ourselves, because at the end of the day, nobody understands those lines. It just hurt us because we want those lines to look perfect, right? So we want to show that when you use biometrics, it is something that at the end, it gives you more experience, that definitely can be put the treatment in a different level of precision, because it's a fact, it's measurable. But it's still the concept of physiology is a chain of actions and reactions that when you start putting everything in the right way, you will expect a positive reaction that if you capture it, that can be a good start. You agree with me?
Okay, so let's look at two different positions. One, you're trying to rebuild someone's bite, and you are one of the experts who I haven't had a chance to watch, but you're one of the many experts that you've had in your series. And you're confident, you're good at it, you get great results, everything works out. There's I bow to those people. I am in awe of those people. They can do things that personally I physically can't do. I physically can't find this jaw posture and seat this jaw joint quickly and easily. Maybe I don't have those skills. What I can do, and what a lot of people can do, is they can cheat. And they can cheat by using certain things and observing certain things and prioritizing other things so that they can provide a better bite. So I see pain patients when I'm normally working. Post-COVID, I'm going to be seeing pain patients, and these patients are going to come in and they're going to want me to solve their problems. Now, if I've got a figure skate and a rock, I'm a little bit limited, right? It'd be better if I was really intelligent and talented like everybody else on your lecture series obviously is. I haven't seen them, but they're obviously intelligent, and they're obviously have great hands, and I don't deny that, and they get great results. But for me, and for many people like me, using biometrics to confirm that we're doing the right thing, to properly help us diagnose, and to assure the patient that we're going in the right direction, I need those things. So if I didn't have those things, I would be retired. Simple as that. Those things allow me to be able to provide the type of treatment that I do, given my situation.
That's a really good question. Good answer. Okay,
Correct.
so let's talk a little bit about traditional neuromuscular cases. Protocols use more biometrics, checking the motion activity, jaw tracker, jaw vibration analysis, or sonograms. What else the T-scan give it to you? And we're really interested to learn the way that you implement it, because I love technology and we try to get every single toy possible. And then honestly, part of what we do is what you see, we're seeing you with the tents and everything. What can be the sequence of that you collect this data? Is the patient coming in? And because we have Ben Sutter with us, right? And he was talking about DTR technique. And he tells us all the process that he has and how he made like a pre-selection of the patients. And every single patient that came into his chair, he take a T-scan to have a record of the bite condition, just like taking a set of models.
Mm-hmm.
And then he prioritized that case based in signs and symptoms, and then he will have a sense how he's going to treat the patient. For you, I know that you more into the reconstructive area, correct me if I'm wrong, and also neuromuscular, orthodontics. So mostly we making additives, right, to the bites. So how are you incorporating the T-scan during the process of the treatment? We really want to learn for that for you.
Okay. Number one, Ben Sutter is brilliant. I love Ben Sutter. He's a good friend, and what he does with his teaching and with his help with patients as well is amazing. Ben, if you're listening to this, I love you, brother. You are great. Number two, I'm seeing these patients come to me with what I said were these three problems. There's a micro-occlusion problem. There's a jaw posture problem that's probably related to growth and airway during the day and at night. And then there's a postural problem from teeth to toes that I want to assess. Now, there's certain things we know. There's certain things that we can't measure just with paper. We can't measure micro-occlusion with paper. And as Ben had told you, micro-occlusion is in microns or thousandths of a millimeter. And so we're actually able to help balance that bite out in a proper position. We're able to affect the neurology instantly on our patients. and get head and neck posture and everything that's improved. Now, I also use, I'm neuromuscular. I love my myotronics, and I use this myotronics K7 to help me find a more happier bite posture. I can't find it with my hands. I'm not that good. But I am able to use this K7 to help me find this bite posture. And this biomechanical, you like to use the term physiological. I like to use the term biomechanical, because for many people that I've lectured, I don't know about you in your past, but a lot of people hate the words physiological because it sounds tough. But biomechanical, we understand, right?
Yeah.
So we used to deprogram people. We used an NTI or a COIS or whatever to help deprogram bites so we could find a new one. My focus is I want to reprogram the bite, not deprogram, but reprogram the bite. So I'm going to look at the posture. I'm going to look at the microocclusion, and I'm also going to look at the biomechanical arc of closure of the jaw into a more stable position, using things like EMGs and everything else. So let's get back to how we use the TENS. If you have Ben Sutter on here, he's explained the TENS. Every single patient that comes in is TENSed. And so everybody gets an idea about what they have going on. That's part of observing, diagnosing, and informing the patient. Now, some patients want discrepancies adjusted. Some patients don't. It's their choice. Life's full of choices.
So every patient that comes to you as a new patient, you are tensing and checking with the T-scan?
I'm checking with the T-scan. I'm not tensing.
Okay.
I'm looking at tensing maybe later on. I got to get this patient interested in what I'm going to do. And what's the best way to teach a patient that they have a malocclusion? Take a T-scan.
Okay, just to clarify, because you were referring the TENS multiple times.
I apologize.
Yeah.
Sometimes I flip those words back and forth. I'm old.
Okay.
Give me a break.
So then T-scan. Okay.
Okay, so all right.
Now,
so not, okay.
Sorry,
Yeah.
Hamid. Sorry, everybody. We're using the T-scan right off the bat. And so we're educating the patient with the T-scan. A lot of patients also have a jaw posture problem. They sometimes, not all the time, but sometimes.
Sure.
And they need that jaw posture problem addressed. So I do that by making the patient an orthotic. And you guys know I have an orthotic in my mouth right now. Should I show it?
If you want.
Javier took it out.
I take mine.
So I have an orthotic, a acetyl resin, anatomical, removable orthotic. If I don't wear it, I get a migraine. So maybe it affects migraines. I don't know. You tell me. But the other thing is when I make this orthotic, I'm using the K7, the TENS, and the T-scan. I'm also, before I make the orthotic, I'm making sure that we have been assessed, this patient's been assessed by this NUCCA chiropractor. And I'm not sure if everybody knows, but NUCCA, N-U-C-C-A, the National Upper Cervical Chiropractic Association. And all they do is treatments that are associated around the neck. There's no snapping things. No. They don't do that. It's a mild pressure in a vectored manner that they get information from both my cone beam CAT scan and from their x-rays, and they're able to figure out how they can gently make that atlas and axis and skull how to fit together. So TENS, I remember Ben was talking about DTR.
Yep.
Yeah.
Where I'm different, I talk about a functional rebalance, because I never know how to spell DTR. I don't know how to spell that. It's a joke. Um,
Okay. Well, Canadian jokes is hard to understand for Colombians, Americans. Okay.
so I do a functional rebalance. It makes more sense to my patients. So I'm rebalancing their bite functionally. I'm getting them assessed by the chiropractor and by what other specialists we ever need. And then I'm using the K7, the TANS, and the T-scan to provide a more balanced posture for the bite.
Okay. How you combine the TENS with the T-scan?
Ah,
I want that you show the tricks. That's what we want to learn. That's what it is. This is all about Hamir and I. We want to get information.
that's just my secret. You know, I pull my secrets out, do
No,
you?
believe me
That's
that
a
we don't have
secret.
many
You
followers
already
out
gave
there.
us
Really?
one. You already gave us one. Another one doesn't make any difference.
Here's it's real easy. If your listeners know how to use the ultra low frequency TENS by Myotronics or BioResearch, they're both great. You know that it's going to pulse the jaw muscles up and down. And what I'm going to do is I'm going to put the T-scan into the mouth. I'm going to increase the sensitivity on the T-scan way over what you normally would do. That's an important part. And I'm going to turn up the amplitude. So just like you would use the T-scan or the TENS unit to get a bite, instead of articulating paper, it's coming up into the sensor, the T-scan sensor, and it leaves me spikes every second and a half on the computer screen. And I can look at those spikes and I can see, oh, I'm hitting more on the right than I am the left. I put in paper, TENS them into the paper, take out the orthotic, look at it. Oh, yeah, I'm really hitting high. Grind those down, put it in, go back to the same thing, rinse and repeat. T-scan, TENS, observe. Then at the very end, because a TENS bite and the clench bite are different when you look at micro-occlusion, I have them bite and slide to one side, open, bite, slide to the other side, open, and I'm looking at their functional marks going left and right with the T-scan, but no TENS.
But we load.
And I'm trying to get a canine disclusion.
Okay.
That's my idea.
Okay. How you control the timing? Because personally, when I'm doing studies and I start seeing it, even that I have my contacts kind of good, that little snake in the middle doesn't, it's not forgiving at all. You know, that's the most difficult part of the game to play with. So you can have all your contacts like that, but you see that freaking snake coming to the side that you don't want. How that affect your entire occlusal scheme? I'm curious about it because honestly, I never get formal training for T-scan. Has been whatever I've been trying with equipment. But what can be the trick in that? You having your pulsing hitting into the sensor. Your marks are kind of equal. You put paper, the marks are in there. But then you put the thing, you see equal contacts, but that freaking snake is still coming like coming for one side. What is that trick into that? What do you think is the looping? What is that? What translate that for us?
Okay, so for the listeners that don't know T-scan, there's a center of force flag. When you bite into your teeth, you may hit this side first, and you may tip or slide, and then hit it on this side, and then finally the bite gets to its maximum intercuspation.
But
And
even that you have your distance equal.
The T-scan is going to measure where you hit first, where you hit second, and it makes this line with the center of force flag, which is a little flag in the middle, and it looks like a snake, like you're talking about.
Yeah, that's the snake that it could.
That's
the Colombia version.
We have snakes. We don't have snakes. We're in Canada. There's no snakes in Canada. Okay, they're not allowed.
Okay, Hamid, go. Sorry.
So what we're looking at is when we pulse them up, we're going to see the first initial touching from the tens, pulsing them in,
Mm-hmm.
and I'm going to balance as close as I can using that as my guide for where are we hitting first. And then after I've tensed and T-scanned, I'm going to T-scan and massage that into a clench. Is everybody perfect the first time?
Oh, not at all.
When you put an orthotic in, oh, high five, we're all done. We don't need to, that's it. Let's light them, have a cigar, have some whiskey, we're all done. We don't do that. What we say is that people have to heal. People don't get better. They improve sometimes instantly, but if you have all three of my problems, it takes a little bit of time for posture to settle out, for ligaments and tendons and muscles to settle out. It takes a little bit of time. But over time, we see that big long snake getting less. It's not as big. And so it allows us to slowly improve our patients, maintaining those three parameters that I talked about. Micro-occlusion, bites imbalanced, bites misplaced, bites being influenced. If we look at those three things constantly with that method, it helps.
Perfect. Okay, Hamid, how much time we have? Can you start with the question?
We can start with the questions now, finally.
Are we going for an hour and a half?
I mean,
No, I think we can I think we can finish it. If Javier doesn't get too philosophical, we're gonna get through it. We can get it. It's Friday night. We don't want to keep the family waiting. Okay, so I think you have answered some of these things up to now, but yes, COVID-19 party. Curtis, what is occlusion to you today? What is it to you? What does it mean? And tell me your influences along the way.
Okay, occlusion is part of this kinematic chain of our body that runs throughout us. Our head's the top block, right? That's what Norm Thomas taught us way back when, of our spinal column. And we will involuntarily accommodate all forms of structural strain throughout our body by using alterations of muscles, ligaments, and tendons. And this includes where our teeth sit and how our teeth function. At one point, we often confuse the terms occlusion and occluding when discussing this topic. I think we're using occlusion right now, which is good. But it's not just when we swallow or chew. That, to me, that's not just occlusion. It's a functional action. It's an intricate dance, both night and day, to help stabilize us. It affects our airway, our speech, our eating, and our structural ability. Change the bite, and we change the sway or the posture that we have. And so that makes me often say it's from teeth to toes.
Right. So you're looking at it from more of a global whole body vision. You're not just worried about how these teeth basically occlude, which is probably what most people think when we talk about occlusion. Oh, just the teeth and the model. That has been a common thread along the whole, with almost everybody, which is a great thing to see, that everybody's looking at it more globally. All right. Prior to stabilization, what factors aside, you talked about posture quite a bit, but you barely touched on sleep or airway, if you want to put it that way. Tell us about all the different factors that you consider for stabilization.
Well, one of the important things I think of is that what I was taught and the first 20 years of my life, people were just stone models. Nowadays, it would be a digital model. We have digital articulators, and all that is all now digital. But I see that there are people that are sitting in front of me. So I find it important to consider all different things like airway, but airway not only at night, but during the day. Because if you want to open up your airway, what does Rakabada teach you? You lift your head up. I saw that in his notes last weekend. You lift your head up. And when you lift your head up, you either got to tip your eyes down or you got to bring your head forward. So you get a forward head posture. And that's going to change your occlusion, because a forward head posture and a back head posture, that's a different bite.
Correct.
So, as I said, everybody comes in as a whole unit. Everybody I see breathes. I see no non-breathers for patients. If you're a non-breather, you're not going to be my patient. So, I know it sounds cheeky, but it's the most important thing in our life. It's what's the most important? It's not your family, it's your next breath. And so I look at this as being the most important way that we accommodate stress and strain is to be able to get a better breath. So these are the considerations that I'm thinking about treating before I'm looking at the stabilization.
Great.
And I'm assuming the joint congruency is part of that. So you're thinking about the congruency or stability of the joint. You're thinking about airway. You're thinking about posture. All these things have to be on the same page for you to consider going to the second phase.
Well, let's put it this way. If I make you a perfect bite like this, is that going to be a stable thing? Because I made you a perfect bite like that.
If you're on a steep hill, maybe, yes.
Let's say that you're just standing normally on cement. Now, you're going to want to tip your head that way. So I got to look at everything. A lot of patients, when we start to look, they have a low shoulder. They have a neck that goes that way and a head that goes that way. That could be occlusal related. That could also be an ascending problem. There's various different complications. They could be complex or simple. These are the things I'm trying to assess in front. And now I know your second question, what type of information do you collect prior and post treatment? That second is I'm looking, I do a series of photographs of people's posture, standing in front of a lined guide. These patients are looking at their posture, their head, neck rotation, whether their body is turned. I'm looking at which foot is in front of the other, if a foot is splayed sideways. I'm looking at how far can they turn their head that way, but they can't really turn that way. Or they can look this way, but they can't really turn their head that way. And what's that telling me about C1, C2 occiput and how those are all involved? I'm also looking at them, how can they bend their knees? Do they have function? What's their gait look like? Then I take photos. So those are photos, a lot of photos. Then I take photos of their mouth. And one of the ones I never see, I mean, we all know how to take photos of the mouth. We're all great. We're great dentists. We know that stuff. But I always do what I call a keyway bite, where I have the patient go tip to tip. And when the patient goes tip to tip in the front, we can see that the wear on the upper teeth and the wear on the lower teeth matches to some degree. And so that tells me that they like to bring their mandible forward. So that also tells me that I'm probably going to have to reposture their mandible, considering they're bringing their mandible forward probably to breathe better during the day, so they don't have to be so extended. I take a T-scan. Everybody gets a T-scan. And then I do muscle palpations on everybody. I do a palpation of the capsular ligaments, much like Rakabada taught. And I also look at does the joint reduce? Is it non-reducing? Is it dislocating? Whatever is happening. So, we look at airway, we look at the oral pharynx, we look at airway for Patty classification, the oral pharynx, the tonsils, the cheeks, the tissues, and the tongue. Those photos are all for that. And usually I get a CBCT.
Yeah, right. That was my next question.
I always use a CBCT especially for pain patients.
Are you taking it with the teeth together?
Yes, I do it with the teeth together. You really don't need to worry about radiation with a CBCT. That whole radiation thing is, in my humble opinion, bogus. And I would like to take a tip-to-tip bite, but sometimes patients are worried about the radiation stuff. It takes a while for them to understand. So I'm looking at airway, like I have UARS, I have upper airway restrictive syndrome. My airway is about 58 square millimeters. And anybody that has a CBCT knows that that's a constricted airway. So I'm looking at that. I'm looking at the cervical vertebrae. Is there a misalignment in the cervical vertebrae, the axis going around the atlas and the occiput up above, and how that's looking at? I'm assessing that. And how does that tie in with the information I got from a T-scan? Because that often ties in. So I'm looking at all.
I'm sorry, do you share that CBCT with your chiro?
Oh, yes, yeah. As long as the patient says yes, and we're going to be using the chiro, I send that off to them. I always share that CBCT with the patient as well to make sure the patient understands what's going on.
Well, sounds great. I think the answer to the next question is fairly obvious because I know you have brought him to our meetings several times. Do you use an interdisciplinary approach in your treatment? And I think you have answered that. Yes.
Hell yes. Not yes, but hell yes.
Yeah. Fantastic. Okay, so would you kindly go through? Let's pick a patient, Javier. A TMD patient, let's say, with the skeletal discrepancy. Can you go over through your sequence of treatment? The patient comes to you today, they have pain, they have some headaches. Can you give us the sequence of treatment? Obviously, there's some vertical dimension that needs to be addressed in here.
May or may not be, sure. So one of the first things I do, Hamid, and I think we all need to do this, is I interview the patient. And the problem with patients is that they quite often don't tell us everything that they should, right? I mean, they're sitting there and they're saying, oh yeah, they're not going to tell us about migraines or neck pain or I got a low back pain or anything else, because why? We're dentists. We're just dentists. We're just the tooth guy. We're just a tooth mechanic. And so what I do is I start every treatment with an interview. I actually try not to do the interview. I let my treatment coordinator, my patient care coordinator, do that interview because they're more open to my female treatment care coordinator. And we have a series of questions and everything that she goes through, and we gather all the information: what type of headaches, what type of pain, whether, low back pain, stability, all this things. Then what we do is we do the photos, we do the analysis, and we diagnose what's going on, we inform the patient, and then we make a decision as to how this patient wants to proceed with treatment. Typically, I'm doing the functional rebalance in my treatment first, because typically I'm seeing a malocclusion, a microocclusion that's off.
That's your T-scan protocol.
T-scan protocol. Now, if we can do reductive, sometimes it's additive. If we can do reductive work on the bite, I'll use the T-scan to guide me to which teeth to adjust, or if I have to add resin to a teeth, how much resin I need to adjust. Once we get that, we're then integrating most of the time with a NUCA chiropractor, National Upper Cervical Chiropractic Association. And we're giving that person information and they're assessing. So they're leaving my office. Bye-bye, see you later. With the understanding, because we do this collaboration all the time, understanding that they're going to reinforce that I need to finish my treatment. I need to do my orthotic, my further T-scan tweaks. And so the chiropractor does their part. They come back in, I take a bite. I don't care if you use what you use, if you're using a K7 or if you're using a figure skate and a rock, I don't care. You're taking a bite somehow, right? Swallow bite, gag bite, anterior, total anterior guidance, whatever you want to call it. However you do it, I'm sure it's perfect. Me, I'm not that bright. So I struggle with things, so I use the K7. Just what I learned works for me, perfect. Bioresearch equally as good. Bioresearch is great, love them. So then I'm going to get an orthotic back. And what are they going to do before I take the bite? They're coming right from the chiropractor to my office because bites can be unstable. And so I want to make sure I take the best bite I can. Before they get inserted for an orthotic, they're coming from the chiropractor. I insert the orthotic, make sure it fits. Because I took an iTero scan to get the models, it always fits. Then what I'm going to do is I'm going to TINS, then I'm going to go TINS and T-scan, then I go T-scan, and then we're going to send them off, and we're going to actually phone them. I don't get them back in necessarily right away because quite often it's a waste of time. I've already got them fairly adjusted. We're going to phone them in a week, 3 weeks, and 3 months. Then I'm bringing them back in. And I'm adjusting and finding out what we do. We also tell the patients, phone us if you got a problem. People don't do that anymore. They do this, right? Phone us if they got a problem. And then they come back and see me. So the protocol is the functional rebalance to help get rid of the micro occlusion interferences, the assessment by someone else for their head and neck. I don't care who you can use whatever you need. If you're in India, it's going to be maybe a couple of chiropractors. If, it's massage therapists, biomechanical therapists, whoever you got. Then it's going to be me taking a bite, taking impressions, inserting the orthotic, and then adjusting it over time. And the more biomechanical or the more biometric equipment I use, the more attention to detail, the less times I have to see the patient.
So I'm gonna jump in because it's a question for Miles Preble. He's an ICMO member as well, and he's asking something specific. So he's asking if you compare the T-scan with the scan 12 in K7. Just for the people that they don't know, so we use 8 different group of muscles with superficial readings that we kind of time in the contraction, and then T-scan goes specifically into the forces of the teeth, and the other one is comparing muscles activities of the masticatory muscles. How you relate those two scans is the question.
That's a good question. I like that. For the first 14 years of learning this, I had no. And so for the first 14 years, I wasn't able to, I had to use scan 12, and scan 12 is great. I thought I was Obi-Wan Kenobi of scan 12. I was Yoda of scan 12. I love scan 12, and scan 12 is great. But sometimes it would say a tooth was high that wasn't leaving a mark. You're going like, what the hell? Or saying, I had a problem on the right side, but the patient's pointing to the left side. What's going on? I had no mark on the right side. So that became confusing. And when I got the T-scan, I would do both. And for several months, I did both. What I found was I could stop doing scan 12. I know that's sacrilege. Frey, I love you. I totally endorse you, Frey. Please don't skin me alive because I love you, man. But I was not using scan 12. I was using the T-scan.
I think it's about proficiency as well. I think T-scan is a lot faster. It can be a lot faster to set up and all that. And we have to think about that stuff. I mean, there is no hard feelings. And
It's more visual for the patient as well, you know. Yeah.
It's a good education for the patient. You know, scan 12 is, you know, that's
Hardcore.
First contact. That's not in their clench. That's not in their side-to-side movement.
Right.
And if I'm trying to get rid of bouncing contacts and working contacts, which I think is important, shoot me, that's my opinion. When I'm trying to get rid of those, the T-scan is really good. I don't have, just let me say, I don't have an occlusal sense. The material, the instrument, I don't know very much about it. I know Ben has it. I don't know if he talked about it or not. And he did a study on the two. But I just happen to know the T-scan. That's the only thing I know.
Perfect.
And the
sounds good. All right.
7.
Number 7, facial aesthetics. When does the facial aesthetic come into your evaluation process? When are you looking at that incisal display or gingival display, lip support and all that?
Well, fortunately, being from Canada, as you well know, every girl looks like a gorilla. So we don't have to worry about aesthetics, right?
No.
I wouldn't say that.
Joking.
This Canadian joker, no, you're gonna
I
get
don't
killed
know.
tonight.
Yeah, we're not, especially from Calgary. I think it must be something with the
You're from
Calgary.
Miami, you don't have a sense of humor? My God. So
we don't mess around with girls.
Exactly.
yeah, you think I get very many girls? Come on, look at me. What I'm looking at, what I'm trying to help patients that have problems is instead of deprogramming, reprogramming, as I said earlier, I'm trying to reprogram the bite. A lot of traditional ways of looking at things would be the aesthetics and then tooth mechanics, and they're keeping a habitual arc of closure. That's cool. That's great. And that's one way to look at things. I look at things differently. I look at the whole body assessment. I look at the micro-occlusion, and then I'm looking at a more biomechanical arc of closure. Now, right at the very start, when we're using an orthotic, I'm trying to give them one that's as aesthetic as possible. But obviously, you know, I'm given a set of parameters to work with, and I have to do all of those things. I have to look at gum tissue. I have to look at you know, where we're going to digitally place or virtually place implants and how we're going to rebuild that tooth. And there's so great prosthodontists out there, they're doing that. What I feel they're not doing is they're not looking at some of the more holistic, with a W, parts of the patient's care. If we just look at aesthetics and leave them as, I don't want to say cripples, but leave them as damaged goods, I don't think that's right. I think that's wrong.
No, our
first.
Correct. No, let's say you are looking at a patient that you are going to treat all those issues through, but the patient came to you because they didn't like their smile. It happens. I mean, they come in and they don't know their problems, and you say, okay, I'm gonna do this, but I'm gonna also put you in the right place. Are you looking at the aesthetic parameters and
facial driven kind of thing
from the beginning, or are you going to first treat the stabilization problem and then try to figure it out later how to,
Let me explain you why we built this question, Curtis.
Yes.
Because many times, and I know that we make an aesthetic analysis, but to a certain point, and we know how much Christian Kochman put into the table with the standardization of facial harmony and facial analysis. And I think that in when we take the bites in the way that we take, as I agree with you, is all big time about the arch of closure. Sometimes we get short in the planning, and then sometimes we have to have vertical dimensions quite open to try to catch up or to compensate the deficit between the uppers and the lowers. That's my
Correct.
point. Because unfortunately, and being true, is many neuromuscular cases that they don't lose aesthetically harmonic into the faces. They have the tendency vertical dimensions are quite big. And of course, that is part of the criticism that we have. So when I started the project with Kochman like 5 years ago, that I tried to focus all this instrumentation technology with the DSD, like the DSD function, part of what I found is that was important even in the first phase to get to have a facial analysis, because that in some way can drive you vertical dimension. Because you know that part of the landmarks that we learn in vertical dimension and facial aesthetics was CJ to CJ that totally break the facial harmony most of the time, right? So then I just trying to address this point, because personally the way that we work is we make a full facial analysis first. And then I start I know what is the flaring of the position, combine it with the tense, of course, because you need to see what is going to be that path of closure. But then you have the chance to take two bites. One that is going to make the, but then you need to have in mind where you're going to be so far you end point, because maybe a case that doesn't present that you will need a little advancement or a little flaring with a little ortho, let's say, because you know that you're gonna hit your ortho closure, sometimes cannot be considered. And ask us how we learned this, because we for many times we were getting the patients in an orthotic, having a stable patient is start pushing because they want to go to cosmetics, and then we will say, okay, let me do the upper arch, and then we close the bite later. And then when we were trying to close the bite, because now you want to remove the removable orthotic and you want to close the patient in the arch of closure, boom, the teeth are in the way. And then you reject and say, my God, now I'm gonna need to lingualize too much the lowers if I want to go to this. And sometimes the only other option that you have is increased vertical dimension. So that's the only reason that we position this, because at least for us was a big thing. We just remaking a full case because we missed that point and we retreat the case, and now the dynamics doesn't work, even that the body works fine. So it's just something that as an experience we say, okay, let's ask the people in general if they thinking in facial harmony in some way to say, okay, this patient has this crowding. Because remember, everything now with this mock-ups thing is that you can visualize even how the patient is going to end up after ortho, right? So you like have an idea, and I say, okay, this patient where I going to end up here, I definitely cannot achieve this with crowns. My teeth, they're going to be in the way. Maybe I will do extra 6 months of arch development, and I will bring that segment out. So when I close my bite, they're going to be a little cleaner. That's the connotation. You follow me?
Yeah, of course I follow you, but you know what I would say, the way I'd answer that question for you is very simple. I would diagnose, inform, and allow the patient to choose a treatment, knowing the parameters of what we have to do. You know, how many patients want upper and lower maxillary mandibular advancement? How many patients do you have that want that?
Now, learning a little bit because we educate. Actually, I don't see it that bad. It's little percentage, but now let me tell you, I met amazing surgeons, and I seen that now a possibility.
Great surgeons up there. You probably had some great surgeons talk today or yesterday.
No, next week.
Great surgeons. So, but we have to get some consensus between what we can do for the patient and what we can't do for the patient. I mean, obviously, if I am approaching, so someone has a bad smile. Why do you have a bad smile? Did you wear the teeth out? Are they just, are they summer teeth? Some are here, some are there, some are over there. What is your problem with your smile? What's our goal? What do they expect? Not what we expect, but what do they expect? One of the things they expect is that there's going to be some form of stability that's going to go forward. One of the things they expect is they're not going to be put into pain. So we have to make that conversation address both those things along with what they want from aesthetics. Sometimes, you can't provide what the patient wants simply because of their limiting treatment or there isn't treatment available for you. So it's kind of a difficult, do I consider facial aesthetics? Yes, by all means. But I consider it in the format of what I give patients information about, which is basically teeth to toes, and what I figure out to be an ideal bite by using an orthotic. So I actually don't, or very rarely, cut any teeth before I figured out where they're going to go, and then at that point deciding, is that going to be aesthetic or not? So it's kind of a complicated question. I understand your process, a little bit different than mine, because you're way smarter than me.
Okay, let's move on.
Let's move on.
There is no right and wrong here.
Yes, it's just different protocol.
We're just trying to pick your brain and see how you go about things. Okay, and this one, I'm not sure if you do any surgeries in your office at all or not, but are you familiar with growth factors, PRGF and PRP, IPRF, and things of that nature?
Not at all. I don't do any surgery, so I got no opinion.
Okay. Should we go, or should we explain what we're asking for? Or?
Yeah, no, because it's fair to hear the opinion. Because go.
So there is build up research and evidence now that injecting these growth factors into the joint is helping with the repair processes, not only the soft tissue but also the hard tissue. So if you have a degenerated condylar heads, it's actually increasing or hastening the healing process and regrowth process.
So that would actually, I do have an opinion. Why did that joint become degenerative in the first place? Why was there?
No, it's all within we know that there is. So the general consensus is, at least with the people who have we talked, that of course the traumatic bite needs to be addressed.
And the space needs to be created. It's just like if you create a space.
Correct. So once you have the patient, hopefully in, like in our case, in an orthotic and protected, do you think? What do you think about injecting these into the joint?
I have no opinions. I don't know. I don't know that research. I've not done it.
Okay. So we invite you.
In Alberta.
Be sure that you don't miss Dr. Alejandro Martinez. That is a surgeon that he used to make like 500 joint surgeries. I think it's Monday.
Monday morning or?
And now I need to double check. Let me see. And anyways, he's talking about how he went for a more conservative approach that made your surgeries to make injection of growth factors and allow the cortication of the condyle again. And there's two friends. This is a maxillofacial surgeon from Mexico, and again, 35 years doing joint surgeries. And then it's another friend of mine, Bruno Ardanza from Spain, that he's been 20 years doing it. Of course, they change the bite, they create the space, but they do the injection. So it's two techniques. Dr. Alejandro is going to talk about this technique in combination with arthrosynthesis. That is the way he does. But the other doctor, Dr. Ardanza, he just do exclusively the injection. But it's something that Hamid started implementing.
Good for them.
and it's a good alternative we've seen for those condyles that they kind of in bad shape. It's a new alternative. He's doing neurosurgeons. Are doing it into the neck and into the hips. And it's been really a therapy that has been evolving more and coming more popular. The more that's why we put it as a question because we didn't know as we started asking. We found actually a neurologist here that he was doing it in the neck, and we didn't even know because we were trying to look for information. So it became really popular. Honestly, you need to check. It's pretty strong. It's not new. It's been long enough. So it's cool. I think it's a good holistic kind of thing. I think you can grow it. So he's gonna be actually Alejandro Monday at 6 p.m. That's gonna
Oh,
be.
good. So that's a good time for you. Hopefully you can join us and watch that.
I will join you as long as you give me the URL to connect.
Oh my God. No, so the audience people know that you just need to go to our pages. That invite you. We invite you to our house, and we thought that you know where we house were.
Yeah.
Okay, keep going. That we have people
Fantastic.
around
All right.
here.
Do you notice, I'm sure this is a yes on your part, do you notice postural changes after your treatment? Expected, unexpected, good, bad? What do you see?
Oh, geez, I wonder. Huh? Yeah, I do. Sometimes they're immediate. Sometimes they take time. You know, the connective tissue, the tendons, the muscles, relaxation. It requires time, but yes.
Let's put it the other way. Do you ever see a bad outcome?
Only with bad treatment.
I mean, I'm saying that, have you ever seen something and said, ooh, maybe something's wrong there, I got to change something?
With what I'm doing after they've had postural changes, yes, sometimes we have to adjust the bite as their posture changes. One thing I want to point out, I think this is probably a good place to point it out. Reducing structural strain is always going to be positive. But remember, pain is not always present. And I always say this, pain's not is not a good diagnostic tool. Not everything's painless or painful. You can have a painless cancer. Would you be concerned? Of course. You could have a painless, partially blocked coronary artery. Are you going to wait for the drama? You're going to wait for the heart attack? No, you're not. So pain's not this metric for health. Health is about our metric for health. And I think that's very important when we start looking at body compensations. These are happening just because we want to survive. There's no other reason for these body accommodations happening. So I think that's very important. You had one question. I'm just looking at the questions.
We're getting there.
We're getting to it. So you have a son in dental school.
Okay, so that was the one I want to talk about.
Yes, you have a son. So when do you think the field as a whole is going to be ready to introduce some of these physiologic ideas to the occlusion taught in dental schools?
So do I think that this physiologic approach to occlusion is going to be taught in dental school? Probably not.
Not just this neuromuscular, but today, I mean, this week we have had, what are we on, Javier, 14th?
15.
15th today, 15th invitee. And I can tell you every single one has had, in one way or another, very, very common physiologic objectives in their approach. When are we going to see some of this, in your view?
I don't think, so you got to understand, my son's going to Rutgers in New Jersey. And all I can say is it's a great school and I want my son to pass. But you understand, a university is turning a non-dentist into a dentist.
Right.
That's a lot of work. The kids have to learn this language of dentistry. They have to learn a different way of how to examine, and they have to learn how to give basic treatments. the dental school really has no time or probably funding to allow that. And trust me, I'm a Canadian paying American prices, and he gets, because he's a foreign student, he has double the fees. So they have no time or funding to be able to teach them some of the nuances that we need. Now, could they up their game with occlusion? Probably. Which occlusion should we have them up their game in? There's so many different thoughts. There's so many different schools. There's so many different ways to look at it. I gave a webinar yesterday talking about the three things: the microocclusion, the bite in the wrong place, and the influence. And one of the statements was, oh, I believe in panky. How do you fix a panky bite? Did you not listen to what I said? I mean, there's so many different ways of looking at this. This person from Korea loves panky, and they want to be fixed with panky. So it's difficult for universities to do this. What I think we have to do is we have to educate the public more. What I think we have to do is not allow insurance companies to dictate to us and what our role is. Because those two things, the lack of public education, the lack of insurance, especially well, in North America, and I think it's throughout the world, a lack of funding to make people happier and healthier is makes me sad. I mean, I'm passionate about this profession, but I don't think universities are going to ever jump there.
Should there be a specialty for this?
Oh, which one?
That was just a joke. That was just a joke.
AOP specialty, the Dr. Curtis Westersund, he's a God specialty. Yeah, let's go with that one. Or maybe the Javier because he's a good-looking Spanish guy specialty. I don't know.
Oh. All right, don't push it out. Good looking, I'm not sure. He's a good guy, but all right. So let's talk about the last question. Thinking about all the internal dynamics and movements in the jaw joint, based on your understanding and your experience, we're asking everybody to tell us what is their opinion of the events happening from a closed position in ideality, opening the mouth. What is going on with the dynamics in there? Are you thinking of a rotation, translation, simultaneous movement? This is a question, hypothetical, healthy joint.
Okay, personally, I think, Hamid, I think it varies. I think we have some TMJ setups that are going to rotate before they slide very much. We're going to have some that slide before they rotate very much. We're going to have some combinations. I think it's totally varied from person to person. We're all unique, and this is a joint that has an accommodation. I think one of the main things, and I'm sure everybody has said this, I'm not the first one, but this is the only joint with a terminal endpoint, and that terminal endpoint is where we bite together. So occlusion is our terminal endpoint for that bite. How that bite's going to react at that point is going to change over your lifetime, over your experiences, over your growth. And I think that it's going to be such a variety thing. I don't really even think about it because I'm trying to think of where can I put the occlusion so I'm not straining the TMJ, straining the middle ear, straining the musculature, straining the neurology. Where can I put that bite to make that better? Honestly, if you cut your joints off, you'd still find a bite. Are you
worried about where are you locating or positioning the condylar head during your treatment? Are you watching in a specific position?
No, why should
not?
I? Why should I?
I'm going to tell you a reason why. Because as bad as it is to have a bite distalized, it's as bad to have a bite that is stretched
too far forward.
It's
Well,
the same. Different symptoms, different muscle breakdown, different pulling, different affecting the congruence of the surface. Rockabato say, well, two joints cannot be loaded at rest. And if you have a condyle that it went really anterior into the eminence, it's going to be two surfaces in the active area that can develop what he described as chondromalacia and many other things that can happen into the joint just because they in a congruence position the entire time. As a fact, that's something that it took me many years to digest it because Rocavaro, for 12 years that we've been doing research together, he always made me aware. And he say, just be careful that those joints doesn't get all the way down to the eminence, that joint is not going to be stable in the long term just because the behavior of the joint by itself. So we care that lately, or not lately, for many years we've been checking since we have all the diagnostic tools. And then we find out many cases, mostly cases involved with airway, they contain that sometimes when you put the TENS, that patient just go boom, and that trespass the biology of the joints by itself. And then we don't want to improve one system and trigger another system. So now we consider a certain limit when we need to know that maybe that's a temporary bite because it's an expression of the jaw to get there just because you remove that influence of the muscle. Now that bite necessarily is gonna bite, that is gonna validate the joint as a function by itself. I think not necessarily means that if you have a comfort position to go to sleep, that doesn't mean that you can wake up with an arm that is numb just because you sleep happy that day in that side that was comfortable for you. But then the next day you wake up with the arm all sore and everything feeling. So it's like a kind of analogy. It's not just related like that. It's just because we get more conscious about it. We stop stretching joints. We start focusing in treat one joint that is the one that has the issue, and be concerned about the other joint that can be healthier. And we don't want to expose it to the same exact as the input. You know what I mean? So that's just based on the experience. And Rocabaro mentioned in the interview that his time as well. He always make us conscious. Doesn't matter what your bite is gonna be. The only part that you need to be conscious about is don't forget that it's still a joint that is biconcave, and still you cannot have it at rest when it's a vector of loading. It's just something that he infused it in my brain, and then I push it hard in Hamid, and we really conscious about
But
that. We don't get those bites that much forward.
but you do take a final shot where your condylar heads are, I assume, at the end, right before going to phase 2, or at some point, or
of
at the
course,
end of it.
of course.
Okay,
And so
So,
so then
certainly,
so
so you do care about where it is. You just don't
uh,
think about it in the
no,
process, and you trust your processes.
honestly, guys, I really don't because I'm looking at all the physiologic aspects of EMGs, of airway, daytime and nighttime, of posture, of comfort of that patient. And that's going to
yeah,
vary so much. That's going to be sometimes how many eminences are exactly the same? Very few. Some are steep, some are shallow. Some patients don't have eminences anymore
No,
because
absolutely,
of
and
wear.
some of
So
the
all of
lecturers
this,
talked about that.
I'm looking at all the other patterns of stability. I'm least concerned about this potentially degenerated joint as to where that's going to sit, because that's not going to dictate how my patient's going to get healthy, in my opinion. You guys, I appreciate your opinion. I appreciate, Javier, what you're saying, that you don't want to load this joint, and I don't want to load the joint either. But
so
quite
let me
often,
ask you this:
this
what do you think about
condition
this
is not
concept?
going to. I'm
I'm
sorry,
sorry.
what?
What do you think about the concept that joints need to be treated as joints and muscles need to be treated as muscles? Or you consider that you can treat joints simultaneously, not meanings, just treating muscles?
We're talking about the TMJ. We're not
Hmm.
talking about this joint here. So we're talking about a very complex joint that has a lot of ability to accommodate a less than perfect human. And
Are
when
you?
I'm seeing that patient, when I'm seeing that TMD patient coming in, I'm not as concerned about the joint as I am about many of the other factors. Am I concerned about capsular inflammation? Of course.
Are you concerned
Am I
about
concerned
adhesion?
about whether or not we have a reduction? Of course. But if I can get a reduction, if I can get this, whatever has been given to me by this patient to function better, I think that's the most important thing.
Did you
And
ever have a case that you seen that the patient had restriction in movement, that you did everything possible to try to relax the muscles, that you start tensing the patient is having a lateral trajectory, you took a CBCT first, and you saw that that interarticular space was overloaded. It matched with some radiolucencies into the condyle that it showed that is some level of active activity in there. You see that is wear and tear in the teeth into that side. And then you relax the muscles and then you tense that patient and you see that that condyle here is still not moving in the way that you want. And the path of the tensing is making a diagonal pattern. Are you consider that is something that eventually mechanically is impeding that that condyle has the freedom that the other condyle has? And then do you think that is something else to treat that joint as a mechanical? Because you say the word biomechanical that I use it a
Biomechanics.
lot because I believe in biomechanics. And this is the proof of the more biomechanical factor. You have an additional capsule that is the product of fibrotic tissue that is not letting those structures, even that you relax the muscles 100 times, it's not going to let that joint to get loose to create a muscular trajectory that can be resemble the health of the both joints. So that's again, I'm just the influence of Rocavaro and everything, and I learned it because my wife case was one of the cases that Mariano I made. We made a research, and we found 15 years of record that I have in my wife trying to treat neuromuscularly, and always I have a problem that the neuromuscular bite was not comfortable for her because the muscles they were trying to get to relax, but one joint was full of adhesions. So the other joint actually get hyper relaxed and she has like a more advancement, but the other joint that was healthy was even doing more the job. So this side never worked. And then we tried 2 or 3 years, different techniques. Then the last conclusion is say, Rocabaro, this need to be, it's impossible. We did everything. And he started, and he said, this need to be adhesions. Let's put in a treatment for that. And then we kind of break it manually. We put pivots for 6 months. And I have all that's the article that I published in Compendium. And then 6 months of pivots on her. And now that joint, I mean, pivots with pushing, because pivots without pushing does nothing. And then we were able, and unilateral, and then we were able to elongate that joint. And of course, then get a muscular bite, but that joint as a structure by itself, we were able to gain for that adhesions, freedom. And now the muscles, so the conclusion is she didn't need to have the jolt to advance as the initial neuromuscular bite was giving her, because this other joint in the other side that was healthy never has to go that front as it did in the first place because the problem was the other one. So that's honestly what we consider these factors. Maybe you do simpler dentistry that the way that we
Javier,
do.
Javier, Hamid said, when you have a normal joint, your
Yeah.
wife's problem is a totally separate parameter, and there's many different ways of going at that. But Hamid said, if you have a normal joint, what do you
Correct.
consider?
No, as we were.
Yeah, yeah,
Interesting. It's interesting what you said. I love what you said, but we're talking about a totally different thing,
Correct. Correct.
and it's totally different than what Hamid's
No, I just made that topic because you say that it doesn't count when that joint end up, and then
Correct.
that's my
Yeah, I
point
think
that I tried to
the
say
point of
is
the
because I'm
Did,
sorry,
did,
because when we
did he
finish the
have this?
X-ray,
Did
that
he
we
have
take
this?
that by, we say,
I
Hold
think
on a second.
the subject changed.
yeah, the
Did,
subject
did
changed,
he
but the
have?
question is right.
Did he have this diatribe with every single speaker that you guys had together?
He does that every once in a
Go
while.
off on
So
this
don't take it personal. He goes.
times today.
That's why
He's
I'm
been
supposed to
talking
be
about his
stopping
I
him. You know,
know.
it's like 7:30 now.
No, just because honestly, it's look. Actually, this can be, I can say, Hamid, one of the toughest interviews because we know what he's talking about because we believe a lot in that, right? So
Right.
we have the same
Yeah.
foundation. It's tough. It's tough to create something educational. Remember, this is not just for people that get exposed to the information. We're still having some educational content for people that they don't know anything about this, and then I'm trying to answer the questions, and this is what I hear for another people saying about us. So I'm throwing those questions that it will have a value. It's just don't misunderstand it. This has no bad connotation. It's just education. That is what I questioning you is questioning me or questioning Hamid. The same thing. It's just that we're trying to find a mechanism to answer questions that we have to the people before. So don't take me wrong, please.
Okay, so you know how do you gauge someone's intelligence? By how much they agree with you. So obviously I'm intelligent because I do agree with you. But there are so many different options and ways people present that your wife's issue is different than many of the issues. I've had patients like your wife that have a locked joint. What are we going to do with that? Are we going to do some arthrocentesis? What is it that we're going to do to be able to help that person? There's many different ways to skin that cat. Actually, there's only one way to skin a cat. You grab him by the tail and you rip towards the head. You do it outside the village because they'll wake up the whole village. And you don't want to do that. But anyway, go ahead. This has been a wonderful 2-hour, half-hour lecture.
I was gonna say that.
That's good. No, because I
Fantastic.
think comments and then Ramsin, I think he say, who cares about time? So I'm just going by him. You know, so we keep
people are saying
going.
we don't
I
care.
got nothing to do. It's Friday night. Nobody loves me.
Friday.
I got nothing to do.
You going out to
Oh,
dinner?
Yeah, going out to dinner, right?
You dress up so nice.
Well,
Yeah.
I'm trying to look. Professional. I've been doing webinars this week and last week. I did Russia, China, India, Vietnam, all these guys. So I try and look professional. And so my wife actually picks out my outfit. She goes, "That looks good. That looks good," and then makes me wear it because I can't choose clothing.
Thank God, she has a good taste. Okay, last question of that. Last question is, how is your occlusal scheme when you finish your cases? What is the occlusion relation? How you did occlude? This is an anatological question, kind of. What you consider occlude with speaker, Wilson curve, anterior guidance, incisal guidance, tripod, cos-fossa relationship. What is the occlusion scheme? This is all just to standardize based on all the guests that we have, try to make some level of tabulation of information.
So we are using very many modalities to get the bite. But I'm not allowing the patient to have any balancing contacts. I'm not allowing the patient to have any working side contacts when they go in function. I'm careful to adjust anterior guidance as well. We're trying to go for a canine disclusion. There's a simple reason for that. These front 6 teeth have neurology that's different than the back molars and the bicuspids. When you go to your canine, your brain's told, oh, you've got a lot of pressure there, you can shut this down. That's great, but if you have one of the posterior teeth touching, your brain's saying, you got a walnut between your teeth, keep clenching, keep grinding. I'm trying to eliminate those interferences. Do I want cuspid, tripod contacts? No, I'm going to get what I can with the worn piece of crap of an occlusion that people give me. And maybe I'm going to make an ideal lower that's going to fit a horrible upper with an orthotic. Maybe we're going to rebuild everything that's going to be totally different. But I'm basically, that's my parameters. Make the muscles happy, make the airway as good as we can, make sure the posture's good, manage the micro-occlusion.
Awesome. Thank you,
Sounds great.
brother. I cannot squeeze you anymore. We cannot squeeze you anymore with information and everything. It has been nice. It's good. I mean, it was awesome because
Fun.
technically, when do you ever have no phone with me? So come on, it's